My first question is for Mr. Dahl. In your testimony, you stated that in 2008, that since '08, your office has opened more than 750 criminal investigations involving the FICA program. How much time do these investigations typically take before they're completed? And then my second part of the question is, given limited resources, how do you decide which cases to investigate?
Thank you. Let me break this up into two quick answers. There's the claimant side of this, the beneficiary side. Those cases are pretty straightforward, and they don't take usually longer than a year. And many of those are handled by the OIG from the affected agency. Except if they're, it's a smaller OIG, then we might assist them. And particularly in getting data from OWCP. We've shifted our attention to the medical provider side because of the greater harm to the program. And we started doing that about 4 years ago. And those cases are more complex, involve multiple parties, sophisticated means, sometimes conspiracies. And they may take 2 years or longer to complete. And because of the resource issue that you alluded to, we have teamed with our law enforcement partners from other agencies that are affected by this. They include Postal OIG, VA OIG, HHS OIG, and others to investigate these matters because we don't alone have the resources to do that.
Another question I had, you mentioned in your testimony that one of the updates that was made is requiring letters of medical necessity. What other best practices and programmatic changes do we need to take to reduce fraud and abuse in the FICA program?
Well, I think that I just go back to Chairwoman Fox's question about using data analytics, both by the OIG and the program itself. And I think that those can be early warning signals that they did not see for compounded drugs. So they can get on top of this, because we all know that fraudsters are not going to stop defrauding a program because we've shut off one spigot. They'll find another place to hit us. And so we have to be vigilant in using data analytics tools to tell us when that's occurring, and putting in place, the program putting in place measures at the front end to prevent the fraud from occurring so that we're not having to investigate it on the back end.
Thank you, Mr. Dahl. My last question is for Ms. Tanabe. You note in your testimony that at least 1 in 15 injured workers in Massachusetts, Louisiana, and Wisconsin filled prescriptions for central nervous system depressant drugs within 1 week of an opioid prescription, and that the rate of these prescriptions was even higher among claimants receiving opioids on a chronic basis. Do you think we need to further focus on the effect that opioid prescriptions may have on individuals' mental health in addition to addiction?
Thank you. It's not clear that from the data that the benzodiazepine prescriptions were prescribed for mental health conditions that resulted from the opioid prescribing. They may have been prescribed for already existing mental health conditions, comorbidities, or even for muscle relaxants. Much of the prescribing for that we see in the data are for cyclobenzaprines, which is a muscle relaxant. Many treatment guidelines recommend an initial assessment of a history of the patient's substance abuse disorders and mental health condition before initiating chronic opioid treatment because of the risks that are involved in chronic opioid treatment. So it's important for future research to look for insights on chronic pain management by studying opioid prescribing for people with mental health comorbidities.
Thank you. My time's expired.